The cloud. All right. Hello, everyone. Welcome back to another Monday Rafael Medina subspecialty session. The focus of today's session is endocrinology, and we have two fantastic guests from UCSF who are going to teach us today. And we have Dr. Rob Weber as the case discussant and Dr. Khine as the case presenter. So I'm actually going to pass the mic to both of them to introduce each other. And again, my name is Maddie. I'm going to be facilitating the session today. So I'll pass the mic to you, and you can go ahead and introduce Dr. Rob Weber.
All right, sounds good. Hi, everyone. So I'd like to introduce Dr. Rob Weber. He completed his internal medicine residency at UCSF. He's our current chief endocrinology fellow. He's about to be a third-year fellow, and he's doing research as well in hyperaldosteronism. Overall, I just want to say he's an amazing clinician, an educator, and also just a really nice person. So I'm so glad that I get to work with him and that we all get to learn from him today.
Oh, that's nice. Thank you. I should be meaner because people are afraid. And I have the pleasure of introducing A. She came to us from chief residency at our sister residency, UCSF Fresno. She is a first-year endocrine fellow about to become a second year, and she will become the chief fellow next year. And she's joining a research group that is studying the endocrinopathies from checkpoint inhibitor therapy. I think we're lucky to.
Oh my gosh.
With you, eh?
That's so interesting. Well, we're all grateful that you both are making the time to be here. And before we dive into the case, I was just very curious if you both could talk a little bit about kind of what made you do endocrinology. How did you find your love for endocrine? Maybe we'll start with you.
Sure, sounds good. So I really like endocrinology because I feel like all the pathways just kind of make sense. But with the symptoms that present, it's always like kind of like a diagnostic puzzle or a mystery to piece it together. And I also appreciate how it doesn't involve just one organ system. I feel like there's so many different aspects to it. So you really get to kind of still treat like the body as a whole while specializing.
Yeah, and for me, gosh, there are at least three reasons why endocrinology is the best. Number one is just like A said, it's a very logical specialty. There are circuits essentially. Number two is that we have treatments and the treatments all work. So like when we make a diagnosis, we can usually fix the problem. And it usually comes down to too much hormone, take away the hormone, or not enough hormone, give more hormone. And fortunately for us, like those are very effective. And then the third is that it's just like, I guess if I had to pick the third, it would be that we also do a little bit of oncology, but our tumors are so interesting because they shoot out hormones and they do crazy things, and they often do not metastasize. So it's kind of like that nice balance of something that's very interesting, but the patients usually do pretty well.
Yeah, wow. Well, I mean, you're probably convincing quite a few people on this call already. So, well, thank you again, both of you, for being here. And let's dive into the case, because I think we're all really excited to learn. So, Bale, thank you so much for scribing. And whenever you're ready, you can start with the first aliquot.
Yeah, sounds good. So I will start off at the point where endocrinology was consulted, just because this patient has been here for quite some time by the time we were consulted. So the initial consult that I received was for a 61-year-old male who now has shock requiring pressor support. So I think here, before we give more information, the question was kind of to ask Rob, like, how he views that from an endocrine perspective, what kind of questions are in his mind at this point.
Sure. So I turn back, what's nice about being a subspecialist is we're all internal medicine doctors at heart. And so I would go back to my schema for shock, which is hypovolemic, obstructive, cardiogenic, and then distributive. If an endocrinologist is getting called, I'm suspicious that we're going to be talking about distributive. And although sepsis makes up the vast majority of distributive, adrenal insufficiency is also in that mix, especially the lack of glucocorticoids, which reveal some of the receptors that epinephrine and norepinephrine respond to. And then also a lack of aldosterone can cause shock. I guess if the endocrinologist is being called, I could think about some causes of hypovolemia, such as uh, high glucose, elevated calcium, um, diabetes insipidus, which is now called ADH deficiency. So I'm kind of, we've got the initial schema, and then I'm trying to figure out why would endocrinology be called about this? Oh, I guess hypothyroidism in the extreme can also be a form of distributive shock.
And Rob, one follow-up question. So
Uh-oh, I lost you there, Maddie.
Oops, 1 second. Are you able to hear me?
Yes, now I can hear you.
Oh, sorry about that. One question I had is, what additional information would you be looking out for? You said, some of the things in your mind are, is this adrenal insufficiency? Is this a thyroid problem? As we go through the HPI, like, what are some additional pieces of the history that you'll be looking out for?
Sure. So, I mean, not so much applicable to this exercise, but in real life, it'd be like, why are you calling endocrinology? There must be another piece of data that we don't know about. But if I was starting fresh and I wanted to know if this was an endocrine problem, I would look deeply into past labs, past medical history, especially autoimmune disease, especially checkpoint inhibitors. I mean, we're becoming more familiar with those. Particularly past surgical history, and if there's no known past surgical history, just looking at the patient for a scar where the thyroid is. I would also be curious for adrenal insufficiency. The top causes in the Western world are autoimmune, specifically 21-hydroxylase antibodies, which autoimmune diseases tend to travel together. So if they have other autoimmune diseases, that can give you a clue. And then outside of the Western world, the top cause is tuberculosis. So maybe I would also want to know where's this person from? If they're from the Western world, have they had exposures to the classic risk factors, homeless shelter, prison population? And then another thought would be HIV, which can cause adrenal insufficiency due to a co-infection with CMV. And then, of course, everything in endocrinology comes down to the medication list and other vitamins and supplements that people are taking. For example, we've had patients who are taking joint supplements that secretly contain prednisone, and then when they stop taking those when they're in the hospital, that can trigger a form of adrenal insufficiency, secondary adrenal insufficiency, when you're taking steroids and then you acutely stop taking them. So basically, I guess in summary, just a really thorough H&P.
Yeah. Well, I know we only give you just one sentence of information to start. So back to you for some more information.
Sounds good. So this patient initially presented with back pain. They also had a complaint of generalized weakness, nausea, decreased PO intake, and non-bloody emesis. I'm just going to go through the hospital course because he had been there for at least a month by the time I saw him for this consult for shock. So he was found to have MSSA bacteremia with an epidural abscess. So for that, neurosurgery wanted to do a laminectomy and abscess washout. He was intubated for that. During that procedure, he had a large black tarry stool. His hemoglobin dropped from 8.5 to 5.2. So they thought he had a GI bleed. He had a scope, which showed an oozing duodenal ulcer. And so he was transferred to ICU for shock for sepsis versus hemorrhagic. Required a norepinephrine drip, was altered at that time, so he stayed intubated. And then after being there for about a month, everything kind of got better. His infection was treated with antibiotics. His GI bleed was stabilized with a clip, and like hemoglobin, everything stabilized, but he was still requiring norepinephrine. So this is when we were called, like, why is he still in shock if clinically in other aspects he's improving? I can tell you a little bit about like past medical history at this point too. So his only past medical history that we had was he has type 2 diabetes, well controlled with an A1C of 6.8, and he's a chronic smoker. And then medication wise, he pretty much said he does not take anything at home. He just takes Tylenol occasionally, but he was intubated, so I wasn't able to ask him for more of this information.
And he came out of sedation fine?
So he came out of sedation, but he was still altered.
Okay, so in sum, we have this 61-year-old gentleman with shock with two, big flags for why he might have shock. One is the sepsis, so distributed, and then the second is the hypovolemia from the loss of hemoglobin from the GI bleed. But then they fixed those things, and things did not get better. And so the question that they're really asking us is, could there be an endocrine cause to this? And I think what they're really asking is this adrenal insufficiency at this point? So two things. One is that there's a disease called Waterhouse-Friderichsen syndrome, which can be caused by any bacterial infection that destroys both adrenal glands. Additionally, the adrenal gland is famous because it has multiple arteries, but only one vein. And so if there's any sort of clotting disorder, that one vein can get blocked, and then pressure builds up and it causes a hemorrhage within the adrenal gland. And so that's why, strangely, clotting disorders can cause adrenal hemorrhage. Anything, classically, this is more of an APLS kind of story, but, I wonder if the MSSA bacteremia could have either gone to the adrenal glands via the bloodstream, or because it's inflammatory caused a blood clot. I haven't really heard of that before, just speculating. And then given the laminectomy separately, I would also wonder about any sort of like neurogenic causes of hypotension, depending on at what level the surgery was performed. In terms of the past medical history you gave us, patients with type 2 diabetes, even well-controlled, are a little bit immunocompromised. A 6.8 is pretty good. We say, anything below 7. And then history of being a smoker, I don't know if that does anything for me right now other than, worried about the intubation. I don't know if that makes him more immunocompromised. Finally, there was one more point I wanted to make. Oh, the reason I asked about how he came out of anesthesia. So if you have someone who is severely hypothyroid, their whole metabolism is slow, and that includes the metabolism of drugs, including anesthesia. So with people with, say, myxedema or near myxedema, they will be very, very slow to come out of anesthesia just because they can't metabolize the drugs away. So it sounds like that is probably not what happened here.
And Rob, if I could ask one follow-up question. So you mentioned, you summarized that this patient with, persistent shock despite pressure support, fixing the GI bleed and the sepsis, you mentioned you were concerned for adrenal insufficiency. And I was wondering if you could walk us through when we should suspect adrenal insufficiency and what most common manifestations of that are.
Oh yeah, thank you for that. So unfortunately, the common symptoms are very non-specific, and they include the things that this patient has, like nausea, stomach pain, a little bit of hypotension, and feeling fatigued, like kind of crummy. So, but those things on their own, I don't think you should go from those things on their own to, oh my gosh, adrenal insufficiency. But those things in combination with hypotension really make you wonder. And then there's a few important considerations here. One is, what time of day is this? Are we going to be able to diagnose adrenal insufficiency? How do you diagnose adrenal insufficiency? Is there something we did that caused adrenal insufficiency? So I'll do those one at a time. Adrenal insufficiency can be primary, which means the adrenal glands are damaged, like we've talked about a little bit already. Or it can be secondary, which means the problem is in the pituitary, and the adrenal glands are no longer receiving ACTH, which is asking them to make cortisol. So mostly at this point, what we're talking about is cortisol. Number two, did we do this? One drug that is used for rapid sequence intubation is etomidate. Etomidate is a steroidogenesis inhibitor. And so could this be the lingering effects of etomidate if that was used? Maybe, but you would expect that that would get better over time. And then the time of day, can we diagnose this today? There's all this stuff about circadian rhythm and cortisol. And so I would expect that if someone is in stress in the ICU, the cortisol should be pretty high no matter what time of day it is, because that's a physiological response. You could do a Cort stim test any time of day. And what that entails is giving a bolus of synthetic ACTH called cositropin, and then about 45 minutes to an hour later, measuring a cortisol level. And there should be a certain threshold. At our institution, it's 14, where below that is an inappropriate response and suggests that the adrenal glands aren't able to respond.
Amazing. Thank you for that incredible overview of adrenal insufficiency and getting into the diagnosis as well. We'll pass it back to you for the next set of data that you have.
Sounds good. And just to follow up, Rob, the patient did get etomidate 2 days before we were consulted.
2 days. Okay. Yeah. I don't know the pharmacokinetics of etomidate, but my vibe, in real life, I would look up to date, but my vibe is that should be enough time for it to wear off.
So I will give you the vitals and exams. So on vitals, temperature 35.7 degrees Celsius, heart rate 83, respiratory rate 16, blood pressure is 99/70. This is on norepinephrine, and he's intubated. And on exam, he's laying in bed, he's intubated. He was actually off sedation at the time we saw him, so he was able to open his eyes. And we actually thought he looked kind of like he had enlarged features. We were like, oh, is this like an acromegalic type of appearance? So we weren't sure, but we didn't know what he looked like at baseline, but we thought maybe some of his features looked enlarged. And then HENT, he was normocephalic, atraumatic, possibly had an enlarged tongue, but hard to tell just based on him being intubated. Pulmonary, he was intubated, attached to the ventilator. Extremities, he had 2+ pitting edema of his lower extremities bilaterally. Abdominal area, it was soft with some possible mild distension. And then his family actually mentioned while we were there, like, oh, we think his belly's actually gotten bigger over time. But it didn't seem that distended to us. And there was no abdominal striae or anything that we appreciated. And then neuro-wise, he was off sedation at the time. So he opened his eyes and he would sometimes like move his extremities slightly, but we weren't able to get much more of a neuro exam than that.
Hey, could I ask, did you take a look at his teeth?
I did not. It was just so hard to see while he was intubated.
Oh, yeah, of course. Okay.
What were you looking for?
Okay, yeah. So, I mean, you've raised the specter of acromegaly, which is so interesting. So first let's talk about like what is acromegaly? What is acromegaly? What does it look like? And then how could it fit into this case? So acromegaly is an overproduction of growth hormone at the level of the pituitary and resulting in too much IGF-1. And what does that look like? Well, famously, this is the one where people's shoes don't fit anymore, their rings don't fit anymore, but their jaw also grows. And what you can see in some cases is spacing in between the teeth that didn't used to be there before. And then they also get the frontal bossing, kind of like think Neanderthal. You know? They also have a bunch of soft tissue changes, which you mentioned. The large tongue is one of them. The fingers, most fingers end kind of in a point, but their fingers will be large, almost like clubbing, but side to side. And they'll have the mechanics hands, which are kind of like, they're described as doughy, meaty hands and sweaty when you talk to them. I don't know about like in the ICU when all these things are happening, but if you see one of these patients in clinic, it's called a diagnosis, that you can make when you shake their hand, a diagnosis of handshake. Like you can feel the acromegaly hand. Their feet, you will not be able to touch the heel, the bone in the heel. There will be so much tissue in the heel. That's like classic, those are the classic findings of acromegaly. How would that fit into this case? Well, we already said there's primary adrenal insufficiency where the adrenal glands are not working, or there's secondary where the pituitary is not growing. So if there's some sort of mass in the pituitary that is making too much growth hormone, that can come at the expense of the other hormones in the pituitary, which include ACTH, which includes TSH, and in the posterior, which includes ADH. I highlight those three because those are the three that are necessary to keep your patients alive. So those are the three most important ones to know.
And Rob, that was brilliant. What labs would you be sending off at this point to help make progress?
Well, I think, the acromegaly exam is enticing. So I think in real life, I think we would look for past labs and we would see like, is there any evidence? Has this ever been checked out before? Has anyone in any note noticed this physical exam before? Has anyone sent these labs before? But one way to frame this patient is that they were walking along with adrenal insufficiency for a long time, and then an insult has tipped them over into adrenal insufficiency. And that can happen. You can be adrenally insufficient and get along for a while. You can also be severely hypothyroid and get along for a while, but it's the combo of being deficient and an additional insult that tips you over. So I would see if anyone has sent a cortisol before, but if assuming we have none of that information, what I would send is a BMP, a TSH, and a free T4. That's for the thyroid axis. We always kind of get like what the pituitary is making and then what the end organ that the pituitary is speaking to is making. So a TSH and a free T4. Depending on the time of day, we could check an ACTH if it's, say, in the morning, and a cortisol. If it's not in the morning, I would probably just check the cortisol and know in my mind that we will have to take it with a grain of salt and that we're probably going to do the concentropin test. And then given the exam findings, I would check a growth hormone and an IGF-1 just because I'm curious. Would I check anything from the urine? Let me think about that. Not at this point, I don't think. And would I check the other hormones? The prolactin, the FSH, the LH, the testosterone? I would not, because this patient is in the ICU, they're under a lot of stress, and some of those are going to be suppressed just from stress, and they're not going to change our management in the acute setting. Would I start steroids right now? It seems like they are stable on one pressor right now, so I might hold off for now, but I would definitely give guidance to the team that if they are looking worse, do not mess around. Give those stress dose steroids. And then some of you might be wondering, like, should we just get the pituitary MRI right now? Or imaging, some sort of imaging right now? And I would say not right now. The theme in endocrinology is because there are so many false findings, false positives on imaging, is to try to make the diagnosis biochemically first and then use the imaging to confirm the diagnosis. So that's kind of like a theme of endocrinology.
All right, brilliant. Well, which of those labs do we have next?
Yes. So let me give you the basic labs first. So for CBC, white blood cell count was 13.6, hemoglobin 8.7, hematocrit 25, platelet count 176. And then for BMP, sodium was 144, hypokalemic with a potassium of 3.3, chloride 116, bicarb 15, BUN 10, creatinine 0.86, glucose 132, and GFR of 99. We did check TSH and free T4 and free T3. So it wasn't done on the day we saw the patient, but they had them done like maybe a week or two before we saw them. And at that time, TSH was elevated to 6.04. Free T4 was 0.67, so on the lower end. And then 12 days later, they actually repeated TFTs and TSH rose higher to 10. Free T4 was lower at 0.5, but the free T3 was normal at 2.36. And then we actually didn't check a growth hormone or IGF. Sorry if I led you astray with
Oh,
the exam, but that is what he looked like. But we did check a cortisol. So the cortisol at 8 a.m. was 1.2. And team was great. They actually did a stim test already with that. So the post-stim cortisol was 8.8. I can also give you an albumin.
oh yeah, please.
So the albumin at that time was 2.5.
Okay, great. Well, you've given me a lot of data here. I'm sad about the growth hormone stuff, but that's okay. So let's start with the white blood count or the CBC. So white cells are slightly elevated, I believe, for this lab. Is that right? 13.6.
Yes, that's correct.
So that might be reasonable given coming off of an infection plus the stress and the demargination of neutrophils. Hemoglobin a little low, but above the transfusion threshold, as we might expect from someone recovering from a GI bleed, and the platelets are reasonable. So we'll set that aside. For the BMP, the potassium a little lower than I was expecting for someone with adrenal insufficiency. So there must be some other complicating factors. You know, a lot of these rules. So the deal is aldosterone and cortisol activate the ENaC channel, which brings in sodium from the urine and exchanges it for a potassium at the most simplistic level. So when that is working, it should be sodium for potassium, and potassium should go down. When that's not working, potassium should go up, like a type 4 RTA. But there might be some complicating factors here in the ICU that don't apply to your typical outpatient. The other thing is I'm going to try to do math on the fly and calculate an anion gap. I think it's 28. Is that right? So that's worrisome. and the bicarb is 15. So there seems to be a metabolic gap acidosis. And if we do the gap here, what did I say? 28, 15. I don't think there's a second process, but I'm doing math on the fly, so I might be wrong about that. But I think what we have here is a metabolic gap acidosis. Now I'll save the cortisol for last. The TSH6 is technically high, but it's not high enough to cause these findings. So I'd say in the inpatient setting, people are under stress, and sometimes the TSH can do weird things where it gets a little bit suppressed. But a TSH of 6 and then 10 can be that suppression coming off, and now the pituitary is recovering and it's starting to secrete TSH again. The free T4 being a little bit low could be consistent with the TSH being a little bit suppressed. But in the inpatient ICU setting, I would not look too closely at this unless, say, the TSH is like above 20 and they have clear signs and symptoms of hypothyroidism. So I'm going to kind of put these thyroid studies aside for now. The cortisol. So as I said in the beginning, anyone in the ICU who has functioning adrenal glands should have a rip-roaring cortisol. Like we're talking 40 or 50. This person in the ICU on pressors at 8 a.m., which is like the right time to check, has a cortisol of 1.2. That is abnormal. On top of that, they got the stim and they only went up to 8.8. So that is also an inappropriate response. There's two ways to interpret this, and I'm not sure which one where we are right now. This could be a partial primary adrenal insufficiency. meaning that there are some adrenal cells, but not all of them. And so they are able to respond to ACTH, but they're not able, there's not enough normal cells to respond all the way. Because in the Khine test, they give a lot of ACTH. You should be above 14. The other way of looking at this is that this is a longer standing than we knew about secondary adrenal insufficiency, a pituitary problem. And how does that match this? Well, ACTH, besides asking the adrenal glands to make cortisol, is also a growth factor for the adrenal glands. And so if you take away ACTH, they start to atrophy. If you have long-standing secondary adrenal insufficiency, like months, it can look like primary adrenal insufficiency. And so we might be in the middle of secondary adrenal insufficiency where the atrophy has begun, but it hasn't quite concluded yet. So that is interesting. And then also the patient had back pain. I'm wondering if that is purely due to the epidural abscess or if it was, if it localized at all to the flank. Oh, and I'm sorry, one more thing. The albumin. So what's the deal with the albumin? Why do we care about the albumin? 90% of cortisol is bound to carrier proteins, and 10% is the free cortisol. The free cortisol is the biologically active fraction. But if you're missing albumin, your bound fraction will be lower. And what we measure is the total. We measure the bound and the free. And so you can get false lows if the carrier proteins are super low. So if the albumin is like, so in like cirrhosis, if the albumin is like 1, then a cortisol of 1.2, you would have to do some sort of correction. There are some papers about this, but you can also just measure the free cortisol, and there's a normal range for that. An albumin of 2.5, I do not think is going to correct a cortisol of 1.2 up to like where it should be, like in the 40s. So I think that's a good data point, but I don't think it explains the picture. I think this patient really does have adrenal insufficiency at this point. What would I do now? I think I would get a CT abdomen and pelvis to look at the adrenal glands, and I would probably go for some pituitary imaging to see what's going on there as well.
And that was brilliant, Rob. I want to go back to your teaching on kind of the process of diagnosing adrenal insufficiency. And so could you clarify, is there a specific cutoff of cortisol value that is diagnostic of adrenal insufficiency? And under what circumstances do you progress to the kind of Khine challenge?
Sure. Yeah, thank you. So it's lab dependent. So, and the deal with that is there used to be an antibody-based lab that would pick up cortisol, but would also pick up some of the similar steroids. And so there was a higher cutoff for that because we knew it was picking up some other steroids too. Now in some labs, there is a mass spec style of lab called LCMS, which just measures cortisol. So the threshold has decreased a little bit because we know now we're not picking up that extra stuff. And so I can only speak to our lab. Any number less than 3 with a normal albumin is adrenal insufficiency. Any number greater than 14 with a normal albumin, and that's an 8 a.m. cortisol measurement or post-stim, is not adrenal insufficiency. But now you have this big area in between that, 3 to 14. That's kind of where you use the Khine stimulation test.
Amazing, thank you. And one last question is, so I see the sodium here is 144, and does that, you talked about how normally aldosterone reabsorbs sodium, and so with adrenal insufficiency, you would expect it to be low. Does that give you pause at all in your, this presumed diagnosis of, or in this diagnosis of adrenal insufficiency, or how are you thinking of that sodium?
It tells me that the patient has a little bit of a free water deficit, but technically, I think in our lab, 135 to 145 is normal, so it's on the upper end of normal. And it's not unusual for ICU patients to have a little bit of a free water deficit, especially from all the insensible losses of being intubated and probably not taking in anything PO. So I'm not reading into that sodium too much at this point.
All right, perfect. Okay, A, back to you for the next set of data.
Sounds good. So Rob, you had asked about CT abdomen. There was a CT abdomen with contrast done, and the adrenal glands on that looked unremarkable. And then there wasn't a dedicated MRI pituitary, but they did do an MRI brain without contrast. We called down to radiology, asked them to review the pituitary gland, and they didn't say there were any specific lesions or like infarcts or hemorrhage noted. So any questions at that point, or should I share what we ended up doing?
Yeah, sure. So darn. So the adrenal gland findings are interesting. I think if they're truly unremarkable and normal, one thing to know about the adrenal glands is that they're kind of small to begin with, and so if one layer has atrophied, like we're talking about the glucocorticoid producing layer, it might be difficult to appreciate that on imaging. I'm not sure, because the other layers should still be intact, and it's such a small organ to begin with. So what does that rule out? It probably rules out some sort of catastrophic bleed if this just happened, because that would look, there would be like a blood clot and the adrenals would be filled with blood. We've seen that before. And it probably rules out infectious emboli going to the adrenal glands. But I'm not sure it rules out the secondary adrenal insufficiency. For the MRI brain, so one thing to know is I think of MRIs as, I don't know if this is right, but it's a functionally it works out. MRIs are like old-fashioned point-and-shoot cameras where you have a certain number of pixels. And so if you get an MRI brain, you're using those pixels on the whole brain. And sometimes you might not appreciate things in the pituitary as compared to like a specialized MRI pituitary. That being said, an MRI brain is sufficient to rule out big masses, big structural problems. And so that is interesting, because that means there's probably not some sort of like big adenoma. It's probably not acromegaly. There's probably not something going on in there that is producing another hormone at the expense of ACTH. Could there still be suppression of the pituitary from another cause, say from medications? Of course, there can be, or there could have been a prior insult that has resolved, but has still resulted in a lack of ACTH production. That can be seen, say in checkpoint, even in checkpoint inhibitor or hypophysitis, there can be an inflammatory phase where there's clearly edema in the gland, and then it can resolve, but once it's resolved, there's still a hormonal deficit. So could that be what's going on here? It's still on the list. What would I do at this point? I think, given our suspicions that the pituitary gland could still be affected based on the Court-Stim test, I think I would empirically give the stress dose steroids at this point and see if there's improvement.
So yes, exactly. We started hydrocortisone 50 milligrams IV Q6H because we agreed, like, regardless of etiology, this patient has adrenal insufficiency, they should be on steroids. And then you mentioned briefly about reviewing like medications and everything. Could you talk about like what types of medications you should really screen for with patients?
Sure.
Because one of the things we thought about was like back pain, like are they getting injections, or maybe you can highlight some of the different forms of meds.
Sure. So the number 1, 2, and 3 would be any source of glucocorticoids. Like I said, there can be supplements that contain glucocorticoids. There can be injections and things like that that are not supposed to be absorbed systemically, but sometimes can. There can be a little bit of suppression from those. And one famous example in our department is a patient who used too much Flonase, which is fluticasone, to the point where they actually gave themselves a little bit of Cushing's disease. So even though, you know, it's just supposed to be a little nasal spray, if you overdo any of these things, you can get systemic absorption. Other things, that can suppress the pituitary off the top of my head are high-dose opioids, glucagon, octreotide. Those are the big ones that come to mind. Yeah.
Thank you. Maddie, do you want me to share the next
Yes,
one?
please do.
Okay, sounds good. So the patient himself could not give us any further information. So I actually ended up calling his wife. And I asked, like, do you take any, like, does he take any medications? And she mentioned, oh, he doesn't like taking like Western medications, but he actually takes a lot of random supplements. And she could not remember the names of them, but I know we previously had a similar case. So I asked, do you take Archer King?
Oh no.
Said, oh my gosh, yes. He takes Archer King. But the thing is that he took it for about a year and then they stopped selling it. He couldn't find it for 3 months. So 3 months before he presented, he had already stopped it. But she was like, he takes so many supplements. Let me bring them all in. So she brought them in and he was taking 3 other supplements. I'll give you the name. I will just spell it for you because I don't know how to pronounce it. One of them is NHAN space SAM space TUYET space LIEN. And this one actually was found when searching online to have warnings that it contains dexamethasone, furosemide, and chlorpheniramine, which is like an anti-allergy type of medication. He was taking another supplement called Linsen, LINSEN, double Caulis, CAULIS, and that one also contains dexamethasone. So basically, when he ran out of Archer King, he kind of was dosing himself by staying on these other supplements that still contain steroids.
Wow.
Such a brilliant example of how important a supplement and full medical history is. Rob, what are you making of this information?
It's great. I mean, not great for the patient, but it's great in that it solves the mystery here. And you mentioned Atri King. I think we should just tell the audience that that is a joint. That is like an arthritis medication from Mexico that some of our patients have been taking, and there are warnings. There were warnings in Spanish. I think there are some in English now that it contains NSAIDs and dexamethasone. So we've certainly seen this before from Atri King, but it's interesting. I've never heard of these other ones before.
And Rob, could you talk a little bit about how you treat and manage secondary adrenal insufficiency, especially in this case, when it's identified that it's from a supplement? You mentioned kind of the stress dose steroids. Could you talk a little bit about how you manage it?
Yeah. So basically, what we're talking about here is secondary adrenal insufficiency, where the pituitary thinks that that there's plenty of glucocorticoid to go around. I don't need to make ACTH, and it kind of like atrophies. Those cells atrophy a little bit as well. And if you abruptly stop providing glucocorticoids, those cells don't have time to recover to make ACTH, and so the whole system kind of like, it's kind of a use it or lose it situation. So if you provide any sort of exogenous glucocorticoid for high dose or a long period of time, you're going to get that atrophy. Dexamethasone is our strongest glucocorticoid, so even relatively small doses, say 1 milligram, are equal to quite high doses of hydrocortisone and cortisol. So how do you treat these people? Well, you have to support them such that they're out of the ICU, but you also need to give their pituitary gland time to recover. And so what we typically do in these situations is we start high dose hydrocortisone, which you've done nicely here, 50 milligrams Q6, is it Q6? But what we'd like to do, hydrocortisone is about a 6-hour medication. What we would like to do is slowly wean them down to a dose in the morning and a dose in the afternoon at about 2 p.m. So we'd say like maybe 8 a.m. and 2 or 3 p.m. And then the rest of the day, they will have no glucocorticoids, but hopefully they're also sleeping at that time. And it's during that time that their pituitary gland has the chance to recover some of its ability to produce ACTH. So the other thing about dexamethasone is that it's a 24-hour steroid, so the pituitary never has a chance to recover. So I think that's the basic. You kind of like use their symptoms, their blood pressure, and their electrolytes to guide a slow wean. In terms of the science of weaning hydrocortisone, there is no science. We kind of make up tapers on the fly. And people are always asking us, like, how do you taper this? And we're like, well, it's kind of whatever the patient will tolerate. But a standard adrenal insufficiency dose is something like 10 milligrams of hydrocortisone in the morning and 5 milligrams in the afternoon. So if they can get to that, that's a good starting point.
And how did you, what happened next with this patient? How were they treated?
Yeah, so we weaned the hydrocortisone dose pretty quickly. So it was 50 IV Q6. And just like Rob was saying, we went down to like 50 IV TID, eventually like 25 IV TID, 25 BID, and then down to physiologic dose, 10 milligrams in the morning, timed at 8 a.m., and then 5 milligrams in the afternoon, timed at 2 p.m. And then he still stayed on that dose. And then the ACTH level returned. It's less than 1.5. So it was low, confirming secondary adrenal insufficiency. And then he's still in the hospital, like unfortunately sick at this point, but the team wanted to know, like, can we wean off steroids eventually? So we actually repeated another port stim test. We didn't think he'd have full recovery yet, but his cortisol at this point went from 1.4 to 11.1. So a little bit better, but his ACTH is improving. It's now 4.6. So his body is starting to respond.
And that's the normal course. First, so there's atrophy of the pituitary and there's atrophy of the adrenal glands. And the first thing that has to recover from atrophy is the pituitary, and then the adrenal glands will recover from the stimulation of ACTH. So there's actually a new guideline that came out about this, and they have this beautiful graph where they show like ACTH and cortisol are both 0, and then the ACTH starts to recover, and then months later the cortisol starts to recover. So this glucocorticoid-induced adrenal insufficiency can take, there have been cases where it's taken 3, 4, 5 years in the most extreme cases to recover, but the majority, I think 50% of people will recover within 1 year. So we kind of follow these patients in clinic and just check an ACTH and a cortisol every 3 months until we start to see the cortisol above 5. And once the cortisol is above 5, then you can stim them and see if they can actually go above 14.
Wow, that's amazing. One follow-up question I had on the tapering you were describing. So, in the adrenal insufficiency, I imagine that you need to replace both the glucocorticoids and the mineralocorticoids. And you mentioned that hydrocortisone is usually the medication that's used. Does that have both activity, or could you kind of explain a little bit more, supplementing both glucocorticoids and mineralocorticoids?
Yeah, that's a great question. For primary adrenal insufficiency, where the gland is destroyed, yes, you need to supplement both. For secondary adrenal insufficiency, no, you just need to give the glucocorticoids, and that's because the mineralocorticoid system is under the control of renin, which, assuming they have kidneys and the ability to produce renin, that layer of the adrenal gland should be intact. So you do not need to give mineralocorticoid. Now, does hydrocortisone have some mineralocorticoid activity? It does. And so that leads into some kind of controversies about shock and sepsis. There have been trials about which glucocorticoid is best, and it seems that hydrocortisone is the best one, and people think the reason is because it hits both receptors, but that's like an area of active clinical research.
Amazing. Thank you so much, Rob. Well, before we pass the mic to Rob to kind of summarize maybe 3 key teaching points you wanted to highlight, I just wanted to hear any reflections that you had about what it was like caring for this patient, and just any reflections you have.
Yeah, so I think this was a really great learning case in that It's important to always review like medications that a patient is taking, whether or not it's on their list, because supplements are actually increasingly common. So it's important to do a thorough history. With this patient who was intubated, we couldn't really gather information from him directly. So getting in touch with the family, getting that collateral information is really important. And then I think the other thing I gained from this is really to kind of look at the bigger picture and tie it all together. So this patient, if you remember, came in with an infection, the epidural abscess, and also a GI bleed, all of which were probably worsened due to being on steroids, but also his supplements contained NSAIDs. So that possibly contributed to the ulcers as well, because it wasn't really clear, like, why did he suddenly have all these symptoms? So I really feel like the supplements tied it all together.
Yeah, it really was such an amazing case to learn from. And thank you so much for preparing it and presenting it in such a brilliant way. And Rob, I'll pass the mic to you to see, if you wanted to highlight 3 key warning points for people to take away.
Sure. I guess the first one is to know how to localize the source of adrenal insufficiency. There's primary, where the adrenal glands are the problem, and there's secondary, where the pituitary gland is the problem. And that the Court stim test can sometimes help distinguish those, but sometimes not. Like we had here, this one could be partial primary or early secondary. So that's number one. Number two is that when it comes to the pituitary, for all of us internists, there are 3 hormones you got to keep your eye on: the TSH, the ACTH, and the ADH. And you can look at those based on cortisol, free T4, and then the sodium, because ADH controls water balance. Those are the 3 that you need to know to keep your patients safe in the hospital. And then I guess the third one would be to know that albumin, to know the thing about basically if there's low albumin, there could be a falsely low total cortisol. And at that point, reach out to your endocrine specialists for help on what to do next, because it's challenging even for us.
Amazing. Well, thank you so much, Rob and A. This was really a phenomenal discussion of adrenal insufficiency, and I learned so much and really appreciate your time and your wonderful teaching. So we will end the session here. Thank you, Bale, so much for scribing, and Anmol for jotting down the teaching points. And I hope you all have a great rest of your days.
Thank you. Thanks for having me.
Thank you.
Bye.